Hi, good evening and good afternoon wherever you are in the world. Thank you very much for joining us for the module number 9, part 2. And we are covering penile cancer today. We had one session on penile cancer last fortnight back. My name is Hamad Athar. I'm the course director for this uro-oncology certification course, and ably supported by the course coordinators, Mr. Zishan Aslam, consultant urologist, Grampian, Scotland, and Dr. Wajahat Aziz, who's the assistant professor at the Khan University. Tonight, we are discussing two important areas. One is lymph node imaging and management by Mr. Anuj Dangi, who's a consultant urologist in UK, and the next portion, which is on minimally invasive surgery and lymph node dissection by Wheel and Raviel, the robot-assisted and the video endoscopic lymphadenectomy and guanal lymphadenectomy will be covered by Mandeep Arora. We have the pleasure of having him a couple of weeks back as well, talking about testicular cancer. So, well, we started off in October 5th last year with module 1 on non-muscle invasive bladder cancer, and we are finishing up tonight with module 9 part 2 on 20th September, nearly a year later. In this period, we have had 23 webinars, over 34 hours of interaction with you guys. We had the pleasure of some of the leading experts from North America to UK, rest of the continent, Europe and South Asia. And now we are on to the last webinar. All these webinars, the recording is available except the last two, this one and the one previous to this, and it will be uploaded soon on the Paus Karachi website, and this is the address. And we will also have this address posted on the chat box. You guys can share it with anyone you like. It's free access. Anyone can go and access this. So the 10th module of our course, which is the culmination of this course, will be the hands-on training workshop, which will take place in Karachi from 10th, 11th and 12th of November. We will be covering hands-on training on animal tissues. We will also be showing, giving you hands-on training on laparoscopy with laparoscopic simulators, with animal tissue as well, advanced laparoscopy, covering most aspects of uro-oncology during these 2 days. On the third day, on 12th of November, we will take you to the robotic simulators, where you will have the opportunity of working on robotic simulators for radical robot-assisted nephrectomy, partial nephrectomy, and so on. There will be those areas which are not covered by hands-on training will be covered in the live semi-live surgery session, which will cover extraperitoneal cystectomy, open radical prostatectomy, orthotopic new bladder, ileal conduit, RPL&D, IVC thrombectomy, etc., penectomy, partial and total, ileal lymph node dissection. So all these areas will be covered, hopefully, in those 3 days. I'm really grateful to both the coordinators, Mr. Zishan Aslam and Dr. Wajahat Aziz, for their unwavering support throughout this course. And Mr. Zishan is going to conduct proceedings tonight as well. Last but not least, I'm grateful to my dear friend Sharif Charania, who has been instrumental in running smoothly this course, and all of you probably know him very well with all the interactions that he has. So thank you very much, Sharif, for being there during this course and for all the academic activities. So tonight we have two eminent speakers, Mr. Anuj Dangi and Dr. Professor Amandeep Arora, and they will be covering various aspects of lymph node dissection in the management of penile cancer. We know that lymph nodes and lymph node removal is a very critical step in the management of this disease. So with this, I thank you very much, and I hand over for the rest of the proceedings of this meeting to Mr. Zishan Aslam to take you through, as is the routine. After these two presentations, we will have the post-test module questionnaire, which will be covering the testicular and the penile cancers. So thank you very much and have a wonderful evening.
Good evening, everyone. I'm thankful for Paus and Jishan to ask me to share my understanding on the topic with yourself. I hope that you would find it useful in your clinic practice. Carcinoma penis is something which is not very uncommon in the Southeast Asia, and I'm sure all of you would have seen the cases and managed them in the clinic. And it's something, the management is very simple in the sense it's very logical, but different institute, different department have different protocols, and it's important to understand the underlying reasons for those variations and then decide what is appropriate to your given patient in the setting you are working in. So to start with, I would request all of you to keep a pen and a paper. I would ask you to write down few things while I go through my presentation, and that would make it really interactive and hopefully useful for you. So can I ask everyone, the participant, to keep pen and paper with you? Let's start. So I would start by presenting this case, that in a clinic, there is a 60-year-old young and fit gentleman who comes with 1 centimeter lesion on the glans. He undergoes an incisional biopsy, and pathologist comes back and tells us this is a grade 3 squamous cell cancer, at least PT1B, based on incisional biopsy. On examination, there are no palpable groin nodes. He is otherwise fit, hypertensive on 1 drug. So can I ask you to write on the pen and paper your preferred method for staging nodal involvement in his groin?
Sorry for interference. You could write down in the chat box as well if you want.
Yeah, that's fine. Thanks, Jishan. And for people who couldn't make up their mind, these are potential options. You may choose one of these based on your understanding. What would be the right way to stage the nodal involvement in this gentleman? You would prefer examination alone, you would request ultrasound guided FNAC, you would rather go for bilateral modified inguinal lymph node dissection, or rather a radical inguinal node dissection, a sentinel node biopsy, or a modified sentinel node biopsy. I hope all of you have made up your mind. Now this is the second case. A similar gentleman, 60-year-old, again presents with 1 centimeter lesion on the groin, but this time the incisional biopsy is reported as PT2 at least. And on groin examination, he has 2 suspicious nodes on the left side, nothing on the right side. He's again just on 1 drug for his hypertension. How would you stage this gentleman in terms of his nodal involvement in groin? If you can please write down for your own reference, what would you offer? In people who couldn't make up their mind, these are potential options which might help you to choose one of the modalities you would choose, whether you would go for inguinal node dissection, either open or video endoscopic, or you would rather go a radical inguinal node dissection, ultrasound guided by FNAC, fine needle aspiration cytology, or you would rather go for excision biopsy, image guided, or if it's palpable, just remove that node and send to pathologist. Now, I'll start with my presentation. There are certain things which are well accepted when we manage carcinoma penis, and they are applicable worldwide. Only 5% of patients present with distal metastasis. That means 95% of patients that come to our clinic, surgical clinic, with obvious penile cancer are potentially curable. Second, penile cancer is one of the most disciplined cancer. It goes from one station to another station to another station in a stepwise manner. It would not jump from station 1 to station 3. It will always go to station 2 before going to station 3. So the progression is quite systematic. From the penile, the original site of tumor, it will go to the groin. From the groin, it will go to the pelvic node. From pelvic node, it will go to non-regional nodes and then distal metastasis. So most people, if they present in the non-metastatic stage, would actually present in various phases of nodal involvement. They may have node 0 status or nodal status 1 as per TNM classification 2 or 3, and their survival depends on when you diagnose them. You can save 9 out of 10 patients with either no nodal involvement, but the survival falls to only 3 out of 10 if you're dealing with advanced nodal involvement. So here is the catch. You catch them early, treat them, you save life. And that's the whole motivation of my talk today. You are all aware of TNM classification. We have just spoken about how the survival depends on the nodal stage at presentation. I will just like to highlight penile cancer was one of the early cancer where in TNM staging, a pathological node staging was adopted apart from a clinical staging. A palpable node can be enlarged due to malignancy, but it can also be enlarged due to inflammation, infection. But a pathological node would, if it is PN1, it is only due to metastasis. So it's more precise. When you have more precise classification, you can compare outcomes better. So what do we want to know in today's presentation? How to catch them early and how to treat them. So when we want to catch a nodal disease very early, even before it is palpable, are there any risk factor based on the tumor grade and stage that can guide us? Yes, there are well-established factors. We all know that. If a tumor is PT1 and is well differentiated, that is grade 1, the chance of having metastasis in groin nodes is only 2%. So 98% of people would be free of any nodal involvement. And that's the group you can keep eye on. On the other hand, a group of PT1 tumor, but it is poorly differentiated or it has a perineural or lymphovascular invasion, the probability jumps to 25%. 1 in 4 person with non-palpable node will have metastasis in the groin nodes. So this is an important fact to know, and these people obviously need treatment because you can save their life by offering appropriate treatment at early stage. Whereas intermediate risk, a PT1 but grade 2, has a chance of around 6 to 8%, and this group can be offered surveillance or a staging, as we will see further. So we always historically started with examination, knowing that the examination doesn't cost anything. As a surgeon, we always examine our patient. If on examination we find there are nodes in the groin, we can be 50% sure that it is likely due to metastasis. But this is a very rough number. If you're not sure, you're just suspicious there is something there, your guess may be as close to 50%, right? But if you find a fixed hard node, which is immobile, you may be 100% accurate. This is from malignancy, provided you have a proof from the biopsy of the penile lesion. So this varies, but nonetheless, having a 50% probability in mind is much better than a 25% probability from the risk factor alone. So it is helpful, so should never be missed. But where examination fails us is other 50% of the nodes which are palpable are due to inflammation. And that's where we won't know what we are feeling is either due to inflammation or due to cancer cell. Examination can be difficult in people who are obese or had a previous surgery. The fat around the node or the scar makes it difficult for us to be sure whether nodes are palpable or not. And obviously, examination won't help in detecting micrometastasis. Nodes are not palpable, but they have cancer cell. Imaging actually helps in certain of those limitations. If somebody is obese and it is difficult to feel for the node, imaging can help you and show the node. Irrespective of previous scar or fat around, it is helpful. And a functional imaging, such as a PET scan, FDG PET scan, can obviously help you little better in differentiating malignancy and inflammation, not 100%. So for palpable nodes, the sensitivity may be as high as 94%. Now you're picking up 94% of the old disease. Though there is small chance, around 5%, the positive node may actually turn out to be inflammation because false negative rate is 5.6%. So taking these into account, for a palpable node, imaging is certainly useful. It increased your probability of having disease from somewhere in 50s or 60% to 90%. But where the present imaging, this is the best imaging we have. The present imaging fails us is it fails to pick up micrometastasis. In people who have micrometastatic disease, a PET scan only picks 20% of them and 80% are missed. And that's a big lacuna. So these people, if treated early, can have outcome of 5-year survival of 80 to 90%. And that's why we should not miss them. And obviously, PET scan still can be confounded as we see there is a false negative rate with inflammation. In literature, there was a mention of a lymphotropic nanoparticle MRI where a ferromagnetic nanoparticles are injected, which are taken by the lymphocytes, and they were then scanned with MRI. Initial reports were very encouraging. In 2004, it was published in Journal of Urology, but we haven't heard of it, and it has almost disappeared from the guidelines. Obviously, the further studies were not so encouraging. That's why it has not been pursued. Now, the big lacuna here is how do we pick up those micrometastases, which both examination and our best imaging fail to pick up. And obviously, it is very rational to think that we have to take help of a pathologist who can section these nodes in thin slices, use immunohistochemistry, and use a magnification of up to 400 times what our eyes can see and pick them. Using this same thought process, probably the Netherlands group in early 90s started using dynamic sentinel lymph node biopsies. What they would do is they would inject a radioactive tracer around the lesion. Actually, in the penile cancer, it's usually the foreskin, if most of the lesions are on in the glands and foreskin, and a patent blue dye to find out the lymph node which takes or drains that, the first lymph node that drains that tumor. Please make note, penile cancer is different from all other tumor. This was first used in melanoma, and usually if somebody has a melanoma on the back, the tracer would be injected to the area around the tumor, and the first lymph node may be in axilla, or it may be in groin. The technique only was meant to reach to the first node, wherever it is. But in carcinoma penis, we treat each groin separately. We always assume the lymph node metastasis is happening bilaterally, and here sentinel lymph node means in each groin separately, we are looking for a sentinel node. So taking that difference into account, they found the first node which took up the contrast in each groin, the dye in each groin, and sent it to pathologist, and they were able to pick up 80 to 90% of micrometastasis patient early. This is a big jump from 20% and the FDG PET scan to 80 to 90%. Then they figure out, why are we missing those 10, 15, 20% of patient? And they figured out the only explanation can be, though the node is involved by cancer cell, but the contrast radio tracer fails to reach those nodes because those lymphatic channels are blocked by the cancer cells, which have probably, they are more than minimal disease. So they thought, okay, let's combine the dynamic sentinel lymph node biopsy with the imaging and histopathology. Let's bring all of these things. If the tumor burden is high, obviously there is high likelihood that morphology of those nodes would be abnormal, and we will use the ultrasound to pick them up and use FNAC and incorporate that as a part of protocol for dynamic sentinel lymph node biopsy. In addition, they said if there is no uptake in either groin, we will explore those groin with vital dye, which is injected at the same time just before the operation. And if nothing works out, we will take out palpable node or just proceed with modified groin dissection. But we will not leave any groin unexplored if it is indicated. With these changes, they were able to increase their sensitivity to 95%. That means they were just missing 1 out of 20. And that's where it has become a standard practice wherever it's available. But if it's not available, modified dissection template in each groin still gives a sensitivity of 85%, which may be almost comparable to the initial dynamic sentinel node biopsy, but the problem here is complication rate is 40%. If I can just go back to the previous slide, and you can see the complication rate at dynamic sentinel lymph node biopsy is around 5%. So comparing that, more patient get the morbidity of the procedure with little inferior outcome in terms of staging. And when we say all these staging, what are we comparing to? We are comparing to radical inguinal node dissection, which is actually the gold standard, but it is definitely the best diagnostic modality, but it is also therapeutic. But morbidity can reach up to 85% in some series, but roughly we say almost 1 in 2 or 50% of people will end up with one morbidity or other. And offering this treatment to people who have only 25% chance of micrometastasis means we are offering 75% of people unnecessary treatment. So over treatment is a risk here. So if we go back to case 1, would everyone agree that for a non-palpable high-risk group, when available, a modified dynamic sentinel lymph node biopsy is the appropriate staging step? If we don't have that tool available, we will have to fall back on at least modified bilateral groin dissection. Now coming back to the second case, the gentleman who had the palpable node on the left groin. If there is something palpable, we can always proceed to, if we are sure we can catch those nodes in between our finger, we can just proceed with fine needle aspiration cytology. If there is a doubtful node, we can always use ultrasound guided FNAC as a tool and find out whether it is involved or not. If it is positive, well, we proceed to the next step. We have staged it, the groin is involved. If it is negative, we have option to proceed with excision biopsy. Either just excise the node if it is palpable, or mark it, target it with the ultrasound guided needle placement and remove that node and send it to pathologist. And if the groin nodes are involved, we need to stage the pelvis and screen for metastasis. Both CT, MRI, and PET-CT are recommended as a part of guideline. The initial studies in very selected population shows PET-CT does better than the CT and MRI alone in picking up pelvic nodes. So now I think I have given enough evidence to say in case of palpable lymph nodes, we can proceed to the ultrasound guided FNAC, confirm whether they are involved or not involved. We may have to sometimes proceed to excision biopsy if ultrasound guided biopsy is negative to be sure we are not missing node, and then stage palpable nodes. So this is a summary. Everyone actually gets an ultrasound plus minus FNAC as the case may be. And if there is high risk group, all patients should get a surgical staging as we discussed before. If there is intermediate risk group like PT1A grade 2, we can have individual discussion whether they want to just be on surveillance or they want to go ahead with surgical staging. And PT1A grade 1 can be safely be observed. So this is a rough diagram of what pathway can involve: a clinical examination of node, clinically node negative, stratify according to risk group, and then decide who needs surgical staging. If you have a palpable node, just get image guided biopsy or cytology and proceed accordingly. Now, how do we manage these nodes? Now we have staged them, so each groin is staged. So this is again a case of 60-year-old gentleman who presents to the clinic with around 1 centimeter lesion on the glans. This time incisional biopsy is reported as PT2 at least. And we have from our previous groin staging confirmation that there are 2 pathologically positive nodes in the left groin during sentinel lymph node biopsy or modified groin dissection, whatever he was subjected to, and negative exploration on the right groin. He is fit and he is hypertensive with normal renal function. If I may request you to write what treatment would you offer at your center for this gentleman. For people who have not made up their mind, I am going to give you a list, but for people who have made up their mind, if you can please write down why would you offer the treatment? What is the rationale behind offering it? These are potential options. Some people may want to choose one of these options for the treatment that they will offer to this gentleman. I hope all of you have made up your mind. And now for patients who have a confirmed low burden in the groin nodes, there is only one treatment, and the treatment is radical inguinal node dissection. Whether you offer it open, whether you offer it minimally invasive, but the treatment remains same. As of today, the guideline, European Association of Urology guidelines say that this treatment should be given with the open route, and on clinical trial, minimally invasive treatment can be offered, but things are going to change. There are many randomized controlled trials that are coming out in near future, and we may have more options. But you have to offer a radical inguinal node treatment. dissection. This has not changed from 1960s. This is the standard treatment and still remains the same. Though there is a very beautiful audit of multi-center institutions, many centers across the world, whether they are following these guidelines or not. In the patient in whom these guidelines were not followed, their chance of dying from the disease was double that of those who underwent the standard treatment, radical inguinal node dissection, as per the guidelines. So it is a serious business. It saves life. And if the inguinal node dissection shows more than 2 nodes are involved, or there is PN3 means there is extranodal spread, or on imaging you found that the pelvic nodes are involved, then there can be a discussion for post-op chemo and radiotherapy. There is no definitive evidence to support it. There are retrospective studies, and the guidelines says you can have discussion on case-to-case basis. A fit patient can be offered chemoradiotherapy. Radical inguinal node dissection, as we discussed, saves life. What most experts would agree is if you save saphenous vein during the dissection, the morbidity is less. What many surgeons would not agree with is what incision has decreased morbidity, whether you should put a time-dependent drainage or a volume-dependent drainage, whether you should preserve a fascia lata or not, whether sartorius should be transposed, whether you should use ultrasonic device, whether you should use glue, because there is no definite evidence available. In future, we expect more trials to come out and guide us better. And complication rate, as I discussed, is not something you can gloss over. Almost 1 in 2 patients will get a serious complication. They may vary from wound infection, skin necrosis, lymphocyte seroma, but nonetheless long-lasting lymphedema. And if you had 3 or more groin node positive on your dissection or extranodal spread, there is a case for going ahead with prophylactic pelvic node dissection on the same side, even if there are no enlarged nodes. If you prove that there are no pelvic nodes involved, you can prognosticate the patient. They will live longer, definitely, but you can also avoid unnecessary adjuvant treatment like radiotherapy and chemotherapy, and hence can be beneficial. Now coming to our last case for today, this again a 60-year-old gentleman who presented with a centimeter lesion. Oh, sorry, this is the case we have already discussed, and I think I have provided you with enough reasons to choose a radical inguinal dissection on the left side and leave the right side as it is. And if the pathology only shows only those 2 nodes were positive, we don't need to proceed ahead with the pelvic node dissection. And the last case, this time a 60-year-old gentleman who has 3 centimeter lesion on the glans, incisional biopsy says it's PT2, and there is 1 fixed node on examination on each side. How would you treat this gentleman? He's fit, hypertensive on 1 drug, normal renal function. If you want some options, you can choose any of these options. Keep it in your mind, and let's see what does the evidence suggest. So if somebody has a non-penile cancer proven on biopsy, nodes are fixed, you don't need FNAC as per guidelines. There is very few other differentials left here. It has to be penile cancer. So you don't need FNAC to confirm it is metastasis or from the non-penile cancer. If you offer such people surgery, it has been offered in the past. Retrospective series, the largest one of 24 patients published from Brazil, gives up a very useful insight. There is a very high complication rate, up to 80%. 20% of these people will die few months after surgery. So if they would not have got surgery, they might have lived longer. almost everybody dies within a year. Average survival is between 6 months to 10 months if they would lucky enough to get chemotherapy after surgery. So these group of people, if you give surgery, offer surgery alone, they are not going to live very long. Most people will not be fit to get a post or adjuvant chemotherapy or post-surgery chemotherapy. If these people are fit for chemotherapy, then response rate can be as good as 50% in some retrospective studies. There is prospective data to say that at least 10% of them can have a complete cure rate. There are many regimens. The commonly used is the phosphamides, cisplatin, and paclitaxel. And of those who respond, 50% of those who respond, and you can offer them surgery, the 50% of them can achieve a 5-year survival. So in short, you can achieve a 25% 5-year survival in this group if they are fit enough for chemotherapy and they were lucky enough to respond and get a consolidation surgery and they responded well to both. So from 0%, almost 0% 5-year survival with surgery around to almost 25% 5-year survival, which is a good outcome. Suppose somebody is not fit for chemotherapy, their renal function is not good, they are old enough, they are not fit enough. There is the option of considering chemoradiation to downstage the disease and see if you can offer surgery. Or if they're not fit for chemoradiation also, you have no option but to consider palliative radiation. There is no data to support any of these pathways, but there is an impact trial which is going on, which is looking for lot of answers. Should you offer surgery first? Should you offer neoadjuvant chemotherapy first? Can you downgrade a disease by chemoradiotherapy rather than chemotherapy alone? And whether the post-operative radiotherapy would be helpful. Hopefully we'll get the answer in future. So coming back to the case 4, I hope most of you would agree this gentleman is young and fit and have good renal function. And if he agrees, chemotherapy, neoadjuvant chemotherapy in first place, and if he responds, consolidative surgery would be the right treatment for him. Thank you. I'm happy to take any questions.
I think, thank you very much, Dr. Dangi, for very comprehensive and with very clear messages for each stage, because it could be a really confusing topic.